Here's my dog Nala on the right. She comes from a very good pedigree of Bouvier's, and she pretty much knows who she is. Me, on the other hand, that's me on the left. And so I did a sports medicine fellowship after my orthopedic residency. I did a trauma fellowship, and then I arrived back in Modesto, California, somewhat confused about who I really was and where my practice would go, and I'll share that with you now. So from a demographic standpoint, this is my practice. There's four of us, all with different subspecialties. Modesto has 200,000 people. You can see that only 18% of our population has a bachelor's degree, and our annual household income is below the state average, so it's a relatively impoverished community in that sense, which reflects the agricultural and manufacturing base. And then our practice demographics sort of are a little bit skewed too. We have a lot of Medicare patients, and you can see just a little bit over half of the patient population are commercial and work comp lives, and thus the patient age range of my practice also reflects this with a decidedly older population. Other interesting things about where I live, I take care of a lot of high school and junior college athletic teams, but the state and the city doesn't mandate or support the use of athletic trainers, which are a critical component of the healthcare team. And when you look in our phone book, when I got to town in the yellow pages, there was over 120 chiropractors and only 18 orthopedic surgeons, and the chiropractors very, very aggressively are all still trying to maintain the primary musculoskeletal care role. This ad on the left is from last week's Wall Street Journal, so we see some things that have just not changed. So here's some things that have shaped my practice. The first, I didn't open a sports medicine center because of what I've just shown you. I learned early on that I had to respond to the needs of my provider. So I had a very close friend, a referring internist, who asked me if I would actually see a patient with a meniscus tear because she did it gardening and it wasn't during sports. So I had to rethink things there. And then ultimately I inherited a lot of joint eligible patients from my older partners. The last thing I would say would be the legacy of my fellowship. I did my sports medicine fellowship with Merv Cross in Sydney, Australia. Merv was one of Jack Houston's first fellows, and he also did a lot of arthroplasty. And when I arrived, he gave me this book that he wrote, Clinical Examination of the Injured Knee. And if you look through this book, it's relatively simple. So I wanted to develop the concept of treating patients throughout the continuum of care, which is one of our topics here. So from early on, all the way through, the elderly phase where we're trying to maintain this level of activity. So I can give you just anecdotally an experience I have with one family, a 15-year-old girl who needed an ACL reconstruction done with an all-inside autograft and a meniscus repair at age 15. That's her. Then I did her other knee when she was 16. Then her mom tore her ACL skiing, and she got an allograft graft link procedure. The father he's also an avid skier and sportsman. He required a chondroplasty and microfracture and ultimately a uni. So I've been able to maintain a relationship with the family through the whole longitudinal aspect of their care. So how does total knee fit into this kind of a practice? Well, we've already talked about allegiance now with respect to doctors and the families we treat, and also the referring physicians. And the other panelists just recently talked about how we're going to have to form these allegiances with payers, specifically for the reasons that we're going to have to find alternative payment methods. And as Ken mentioned, the SGR legislation specifically discussed this, and it not only offers incentives if we choose alternative payment methods, but over the next 5 years, we're going to see a 9% cut in our Medicare reimbursement if we choose not to do the same thing. And this is also what's going to drive us into an outpatient setting. We've talked about the increasing demand. This is from a financial perspective. It's not only a boon, but it's also a burden to see all those knee arthroplasty cases being done and what it's going to cost society. We see demand in multiple directions. One is from the consumer side, because the patients who were born up to 1964 who are increasingly active want to do so, but we also have an obesity problem in this country, and not just where I live. Every place you go, people talk about the obesity problem, and like it or not, we can restrict their access to this type of care, but they still are going to need treatment of their osteoarthritis. And to some degree, direct-to-consumer advertising is playing a role, if only to give our consumers more information about possibilities to treat their increasing arthritis. From our side, the outcomes data is actually good, because we're seeing and validating the fact that the procedures we do are good. The engineers have continued to improve things from a polyethylene design as well as and manufacturing, as well as the actual implant design. We also know that better outcomes come with younger patients with less comorbidities. And then this study from the Journal of Rheumatology, basically looking at cost-adjusted quality life compared to renal dialysis, you can see total knee arthroplasty is very low, just above thyroid screening and phenylketonuria screening in children. So I took upon myself to say, well, how do sports surgeons feel about this? And some of you may have received and had an opportunity to participate in this survey that I sent out over the last couple of weeks, and I appreciate it if you did. We're still looking at the data, but the conclusions early on, we had about 300 people that we sent it out to and got a 30% response rate, which I felt was quite good. As expected, most sports medicine surgeons spend their time on soft tissue pathology in the knee, but pretty much everybody said, we see the opportunity, as the question has been asked here today, of doing more of this in the future. There are some problems. We've all talked about this already, that the 92% 15-year survivorship really uses revision as an endpoint. That's probably not appropriate, because when you look at Mancuso's study, when you added an exercise component to people's satisfaction with total knee arthroplasty, it went way down to 78%. And if you looked at all expectations, we have to do a better job of managing these amongst our patients. And lastly, if we're going to do an exponentially increased number of total joints, we are going to meet the revision and readmission burden, which is going to be more expensive, and also mandate that we have much more scrutiny and care in taking care of these results. How I see Arthrex fitting into this, we've talked about the iBalance product line, the education that's provided starting with residents and fellows and surgeons, and uniquely, I think, to some degree, the team of representatives for the company are exceedingly well trained. Outcomes data is going to continue to be not only encouraged but mandated by the government and the other payers, and certainly all of us are on board with that. My experience so far with iBalance Knee, I began about a year ago. I've done 50 of them. I have a lot of experience with the other major ones over my 25 years in practice. I did a very large series of consecutive navigated knees when that was supported early on. I've started my SOS data collection, and I've had a very good success so far with my iBalance knees. Most importantly, no readmissions and no manipulations and good range of motion. Here's what I see the advantages of the platform. It's vertically integrated. I, as a sports medicine trained arthroplasty surgeon, believe very strongly that acknowledgement and treatment of soft tissues. We've talked about this with unis, and I think it's really important with total knee arthroplasties as well. We see this a lot like with valgus knees, for example. The ability to have an internal brace and other options from the same company is good. The ability to measure outcomes. My hospital, over the last year, we got very involved in the California Joint Registry, which delayed my involvement in SOS, but now we're on board with that as well. I see some challenges for the company, for sure, which Matt has talked about. We're going to continue to develop a much more robust platform that includes all of these types of options. Being progressive and competitive with instrumentation with everybody else in the marketplace is certainly an issue. The training and retraining of sports surgeons to be arthroplasty surgeons, that's going to be a challenge, and that's going to require a lot of work on not only the company's part, but on all of our parts as well to keep up. And lastly, when you develop a new product, you have to develop that trust relationship that goes in multiple directions. So this has also been discussed. This is the direction that things are going with respect to how patients make decisions in terms of medical homes, patient-centric care, where we have to be the drivers of this to balance the patient expectations and using evidence-based medicine to make these decisions. So my conclusion, you can't be a purebred sports medicine surgeon anymore. To increase your patient base and retention, you have to sort of broaden your horizons and redefine yourself. This is the way people will think of you as a knee doctor, not just a sports medicine doctor or a shoulder doctor or your orthopedic surgeon.